You guys have the same question that I did when I was asked to do this. That was, what in the world can a pediatric hospitalist share with a group of psychiatrists that will be meaningful to your practice? I tried to approach developing this as with that question in mind. And so what I thought would be interesting to do was look at where the roots of opiate use in the United States, and then more specifically in our region, have come about. Try to weave in where neonatal abstinence plays into that story. Then talk a little bit about what neonatal abstinence syndrome is, and finally wrap up with some introductions to what our group's trying to accomplish. Use the projects that are in development by that group to highlight some gaps in our knowledge, areas where future research is needed. I'm not going to embarrass anybody by singling you out as the only person not raising your hand if I were to ask about who's aware of the crisis of opiate use across the United States. It's very well documented, very well publicized, especially in the regional news, as the talk about opening a methadone clinic has been swirling for several months. That crisis is more focused in our region, as this image shows. This is an image of the per capita opiate prescriptions across the United States. And the darker purple are the areas of highest concentration. As you can see, we're right in the middle of it, and it kind of fans out from where we are. When we look at the number of prescriptions for opiates across the United States, Tennessee ranks number 2. We missed the number 1 ranking, second to Alabama by 1/1000th of a prescription per person. So if you take, about 6.5 million across the state, so somewhere between 6,000 and 7,000 more prescriptions, and we could have been number 1. We're also known for writing high doses of prescriptions, number 2 in that, and for combining prescriptions for opiates with benzodiazepines, number 3 in the United States for that. What this data leaves out is non-prescription use, abuse of opiates, and also the use of opiates for medication-assisted therapy. And so these numbers are probably actually quite a bit higher in our region than what these data represent. Along with increasing use of opiates come the consequences. So over the last decade, as we've seen the use of opiates increasing, we've seen overdose deaths attributed to opiate use increasing as well. Across the United States, that's been 4-fold. And what I'm talking about today, neonatal abstinence syndrome, over the same time frame has increased 3-fold in the US. If you look at this graph, though, you'll see that that's a much larger increase than 3-fold. That's Tennessee specific. In Tennessee, we've seen the incidence of neonatal abstinence syndrome increase 7-fold over the last decade. So a developing crisis, something that I think I've heard the word epidemic actually be used to describe. So as I mentioned before, I think it'd be kind of interesting to look back and see, where did opiate use start in the United States? We'll start back in the 19th century. Morphine was first purified from opium in 1803, and about 20 years later was commercialized for sale. It's thought that the recreational use of opium in the United States began about 1830 to 1840. In that time frame, we saw a large immigration of Chinese workers come to work on our railroads out on the West Coast. And for about a century before, opium had been used recreationally pretty extensively in China. It was something that the British Empire had used to offset their trade imbalance for tea with China. And it's thought that the Chinese workers brought the recreational use smoking, opium, to the United States when they came to work on the railroads. The first case of something called congenital morphinism, what we now know as neonatal abstinence syndrome, was described in Germany about 50 years after morphine was first purified. It'd be another 20 years before we saw it described in the United States. And I have to give credit to Stephen Patrick, who is a neonatologist at Vanderbilt, for pointing out that this description actually came from the literature in Tennessee. So the first case of congenital morphinism was described in Tennessee over 120 years ago, if my math is right. It was reported by a gentleman by the name of T.J. Happel, Trenton, Tennessee. He did a case series of several women who were addicted to morphine. And in this case series, 2 of those women had pregnancies during their use of morphine. The first woman had 3 children over the course of 5 years. All 3 were described as having restlessness and nervousness within the first 24 hours of life and passing away by the 5th day of life. He treated a fourth child a couple of years later who had the same symptoms, but he treated them with a mixture of paregoric, which is an opium preparation, and whiskey, nice classic Appalachian treatment regimen. Weaned the child over the course of about 2 weeks, and that child survived. And the second woman included in this study, her child was described as puny, cyanotic, and troubled with diarrhea. Restlessness, nervousness, diarrhea, failure to thrive, respiratory distress. These are all symptoms that we recognize as being part of the neonatal abstinence syndrome. The last date that I'll point out in the 19th century is 1898. A pharmaceutical company began to manufacture a medication called diacetylmorphine. They had marketed this as a non-addictive substitute to morphine. Is anybody familiar with the brand name for that medication? Heroin. Probably one of the more addictive things that we know. And that brings us up into the 20th century, which I would describe as kind of characterized more by efforts to regulate opiates in the United States. In the first decade, recreational use of opium was banned in the United States, and a short time later, the Harrison Narcotics Tax Act was enacted. This sought to regulate the production and sale of opiates in the United States. It was still legal for physicians to prescribe it in the course of practice, but treating addicts was not recognized as a legitimate practice at that time. So all of a sudden we have recreational use of opium banned in the United States, many people addicted and no outlet for that addiction. Heroin was ultimately banned altogether in the 20s. But we saw a couple of significant heroin epidemics in the 20th century. Both of these followed international conflicts. The first one followed World War II. At that time, the mafia controlled the export of opium out of Turkey and used their connections to flood the East Coast through New York City with cheap heroin. And similarly, in the 60s and 70s, the United States allied itself with drug lords in Southeast Asia trying to stem the tide of communism. In exchange for their agreement to fight communists, we gave them air transportation, guns, and ammunition. And they summarily turned it back on us to start smuggling heroin into the West Coast of the United States. During that second epidemic is where we saw the classification scheme for controlled substances that we now know today, the 5 classes that we prescribe come about. Between the 2 epidemics in the 20th century, we saw a case review published that described the features of congenital morphinism. At that time, it was recognized as an extension of withdrawal in adults. Without treatment, mortality exceeded 90%. And with treatment, we only saw mortality decrease to about 30%. Treatments of the time included various opium preparations that I've included there. If anybody dives back into the literature, these things aren't used any longer, and so they were unfamiliar to me. So I looked them up to share with you today, including tincture of opium, Dover's powder, paregoric, and phenobarbital. You'll see that a lot of these things are solutions containing alcohol, honey, anise, camphor gum, things that are unhealthy for neonates in and of themselves. And it's out of congenital morphinism, this construct of congenital morphinism, that our current terminology of neonatal abstinence syndrome evolved. How I would define neonatal abstinence syndrome is that constellation of signs and symptoms that an infant exhibits when they've had an abrupt withdrawal from a substance to which they were exposed in utero. When you look at the literature, this almost exclusively refers to opiates. We don't see a withdrawal syndrome from stimulants like cocaine or methamphetamine. What we thought was a withdrawal syndrome from SSRIs now looks to be more toxicity from exposure in utero. And benzodiazepines don't have a lot of research on their withdrawal syndrome. It seems to be lumped into the research that's been done with opiates. We use the same tools and the same approach, and there's a lot of critiques about that. So when you look at neonatal abstinence syndrome in the literature, it almost exclusively refers to opiates, or most of the research has been done in the use of opiates. The symptoms of neonatal abstinence syndrome can largely be grouped into three categories. The first is central nervous system excitation. Infants will develop tremors. They'll be very easily stimulated or agitated. They have sleep disruptions. The second category is autonomic instability. We'll see temperature fluctuations, usually on the high side, approaching fevers. Infants will become tachypnic. They'll have uncontrolled sweating and bouts of sneezing. And then the third is GI dysfunction. Infants have trouble feeding, trouble with diarrhea, profuse vomiting. This graphic here, which I'm afraid it's not projecting as well as I had hoped, I'm sorry, shows how each of these symptoms have been traced back to certain neurotransmitters. Increases in acetylcholine, increases in noradrenaline and corticotropin, and decreases in the production of serotonin and dopamine have all been traced back to upregulation of cyclic AMP. An effort's been made to delineate certain risk factors that can predict which infants are more likely to withdraw. One of the things that we recognize most is the adequacy of gestation and the adequacy of size at birth. So term gestation, appropriate for gestational age. It's thought that infants that are born preterm or smaller don't have the development of their nervous system to really display the signs and symptoms of withdrawal, and so probably go underdiagnosed, underrecognized. Certainly polysubstance abuse increases the risks of withdrawal, particularly with concomitant use of benzodiazepines. We think that there is a dose relationship with the substances that mother is using. We have seen that with methadone. Studies on buprenorphine haven't been done to the same degree to draw that conclusion. And with those, there appears to be a threshold effect, wherein at the doses that are most commonly used in medication-assisted treatment, we see infants withdrawing. The dose effect happens at things that are at doses that are much lower than what are commonly used in clinical practice. The only thing that we found that protects against neonatal abstinence syndrome is breastfeeding. And what is thought is that just enough of that medication is passed along from mother through the breast milk to temper the signs of withdrawal. I'll apologize a little bit. At this point, I'm going to take a little bit more of a clinical bend, and I know that as psychiatrists, you're not likely to care for infants that are developing neonatal abstinence syndrome, but it's challenging to talk about NAS and not cover this topic. When we are approaching an infant that's been exposed to opioids in the womb, it's been recommended by the American Academy of Pediatrics that nurseries adopt a protocol. Protocols have been shown to result in decreased lengths of stay for infants. As early as 1975, Finnegan and her colleagues showed that the length of stay when a protocol was used was decreased by 25%, and the use of a replacement treatment, an opium-derived product, paregoric at that time, decreased by about 30%. More recent studies have confirmed these results, showing lengths of stay decreased by 25 to 30%, and the use of morphine or methadone decreased by 30 to 40%. The recommendations suggest that, or encourage that protocols cover screening infants for exposure, having a standardized approach to evaluating them for signs of withdrawal, and then a standardized approach for management. And I'm going to tackle each of those over the next few slides. It seems to me that the need to identify infants that are at risk for neonatal abstinence syndrome almost implies the need to have some screening devices. One of the most effective screening devices comes from the history. Certainly if a mother presents and says that she has been actively abusing medications or has a history of drug abuse, our flags go up that that child might withdraw. So the maternal history is quite important. Mothers who abuse medications, or even those that are in medication-assisted treatment programs, don't often present early for prenatal care in their pregnancy. So a history of late prenatal care or kind of spotty prenatal care, maybe they present, but they've only had a few visits where you would expect closer to 8 or 10 visits over the course of their pregnancy, may suggest that an infant has had an exposure. There are certain complications of pregnancy that are more likely with exposures, things like placental abruption, hypertensive episodes, thromboembolic events. And then if a mother has a strong history of unexplained miscarriages or late-term fetal demises, all of these things kind of raise our suspicion for a potential drug exposure. There are a few different ways that we can screen infants. We can screen their urine. We can screen meconium, that thick, tarry, nasty stool they first produce after birth. And more recently, we've started to screen other tissues. Each of those have their pros and their cons. Urine is a very quick test that is available typically on site. The downside is that it only has a 1 to 3 day half-life of detection. So if a mother has been using a substance throughout the pregnancy and stops a week before delivery, we're unable to detect it at that point. Meconium can detect exposures after the 20th week of gestation. However, it is very easy to contaminate that specimen, and it requires a minimum of a week to turn around results in most situations. Our nursery uses a lab in Utah, and so we don't typically see results for between 1 and 2 weeks on meconium. And so the clinical utility of that test as we manage infants is greatly reduced. And similarly with other tissues, you don't have the problems of contamination or collection, but the turnaround time is about 5 to 7 days on umbilical cord tissue is what we're currently testing. Again, of limited clinical utility when we're trying to make decisions on day 3 and day 4. Excuse me. The policy statement that the AAP published in 2012 also recommended that we have a standardized approach to evaluating infants withdrawal. As I mentioned earlier, it's been shown over the last 30, 40 years that using a standardized tool to assess infants can reduce both their length of stay and the likelihood that they are treated with a replacement therapy. I've categorized on this slide a number of the different tools that are available based on the Neonatal Abstinence scoring system, what you guys may hear called the Finnegan scoring system. There have been a number of modified scoring systems based on that listed there. And then another one that came about in the 1970s, the Neonatal Drug Withdrawal Scoring System, also known as the Lipset scale. These scales are typically administered every 3 to 4 hours over the course of about 4 to 7 days to identify signs of withdrawal. And I'm going to focus in on one scale called the Modified Finnegan Scoring Scale. The reason I want to focus in on that one is twofold. If you look at the literature, somewhere between 50 and 60% of publications use a modified Finnegan scoring scale when reporting their results. The other reason is if any of you guys want to join our collaboration, modified Finnegan scoring system is the system that's used pretty much in all birthing centers across our region, and so it's what you'll encounter. It was, the modified scoring system is adapted from the original scale developed by Finnegan and her colleagues in 1975. At that time, they assembled all of the signs and symptoms that they recognized as being a part of neonatal abstinence syndrome, categorized them, and then ranked them according to their idea of their severity. Mild symptoms were given a score of 1, severe symptoms a score of 3. The most severe symptom is seizures, and that is not projecting well at all. I apologize for that. And that got a score of 5. An infant's total score is summed from all the signs that they're showing at a given interval, and that becomes their Finnegan score. In the original study, it demonstrated decent inter-rater reliability, somewhere around 82%. With follow-up studies and some pretty intense education on its administration, we're seeing some pretty good scores in the 90%. That's what we get at our facility across the street. It was also validated at the time against both the standard of care at that time, which was just clinical judgment, and against a more objective measurement, sucking studies. Recall that when we talked about symptoms just a few slides back, poor feeding was one of those symptoms that characterizes neonatal abstinence syndrome, and discoordination of suck is one of those things that contributes to poor feeding in infants. When they looked at suck, they were able to demonstrate that using a assessment tool not only increased measures of suck, both how long an infant would suck and the frequency of suck and the number of sucks they would take on a pacifier with treatment, but they also found that in an untreated population, the sucking scores actually increased as well. And how this was interpreted was that using these assessment scales, we're able to better identify those that don't require treatment and those that do. It's been validated since that time in term infants. Zimmerman Bear and colleagues back in 2010 looked at the use of this scale in healthy term infants with no known exposure and found that the cutoff score that is commonly used as abnormal, a score of 8, does hold up to about 5 to 6 weeks of age in unexposed infants. We call it modified because we've had to remove a few of the items based on the way that we care for infants now. In the original scale, they use excoriations of the knees and of the nose because infants were laying on their bellies back then. And about 20 years ago, the Back to Sleep campaign, we flipped babies over and we no longer saw those excoriations. So that's why it is a modified version. Despite the advantages of using a scale, such as the modified Finnegan score, it's been challenged for complexity and internal consistency. A few moments ago I mentioned that it requires a great deal of education to bring our inter-rater reliabilities up to 90%. At our facility, we actually use a second confirmation by an independent nurse of any scores over a certain threshold, simply to ensure that we are using the scale correctly. So these are long tools. They are they're complex tools. They also don't have really great internal consistency. A recent publication by Jones and colleagues looked at each of the individual factors and how they correlate to a diagnosis of neonatal abstinence syndrome that requires treatment. What they found was that a measurement of the internal consistency called Cronbach's alpha, which looks to assess are all the questions asking about the same construct? Are all the things that we're incorporating into this scale looking at this thing called neonatal abstinence syndrome? Found that the internal consistency is only about 0.38. And a good score for that, for those of you that may be unfamiliar with that, as I was when I first came across this article, is 0.7. Okay, so a very poor internal consistency. When looking at individual factors, they also found that a number of them are negatively correlated with the need for treatment. You can conceptualize this by looking at a child exhibiting mild symptoms. Mild tremors versus severe tremors. You can think that a child that has severe tremors has more severe withdrawal. Mild tremors actually is negatively correlated. So a child that was having mild tremors was getting points towards treatment, where we actually probably should have been subtracting them. A number of authors, with some of the scales that I showed you on the, I think it was the last slide or 2 slides back, have tried to tackle some of these challenges, removing those things that are negatively correlated or shortening the form. And none of them have performed any better than the modified Finnegan score. And since it's been widely adopted already, none of these other things have really been adopted. There's a lot of variability in how we manage infants with neonatal abstinence syndrome. So as we are administering these scales, we're looking for signs of withdrawal. A lot of the variability that you'll find in the literature stems from either the use of different tools, comparing the use of the Finnegan score with a cutoff of 8 against a different tool that has a cutoff of 6. How do you relate those conclusions? But even in the use of the similar or the same tool, apples to apples, for example, you'll see that there are different cutoffs used for different interventions. What has been widely agreed upon is that the first thing we should be doing for infants is non-pharmacologic care. What I mean by that are things to minimize stimulation. Remember, children are excitable, restless, and so by dimming the lights in a room, turning down the noise, preventing or minimizing how much they're separated from mothers, all the things that we don't do when we admit these infants to the NICU. We can have a decreased need for medications involved in their treatment. We can decrease their lengths of stay. Infants have some self-soothing techniques, such as sucking, being swaddled. So those have both been shown, offering pacifiers, swaddling infants, to also reduce the lengths of stay. And nutrition therapy is a very important part of this. With the many of the symptoms that they exhibit, things like tremors, excitability, disrupted sleep patterns, metabolic needs are increased. Not only that, but with diarrhea and vomiting, they don't tolerate everything that we give. And so this combination of factors, infants that are withdrawing oftentimes need as many as twice as many calories a day as an otherwise healthy child without exposure. And then physical therapy can be effective in teaching families infant massage techniques, again, another way of soothing infants. So it's widely agreed that we should be doing non-pharmacologic interventions at some point after withdrawal symptoms begin, but before we institute pharmacologic interventions. But there's no agreed upon threshold for the intervention to start medication. What a lot of that concern surrounds is that once a medication is started, we're committing a child to a longer course in the hospital. It seems that there is some consensus building around a cumulative score of 24 using the modified Finnegan score over 2 or 3 serial assessments. However, I'll tell you that even across the street, we use a different measure than that. So even with that consensus building, there is a lot of question over at what point we should be instituting medication therapy. General guidelines to guide that is that if you are continuing to have significant symptoms despite the non-pharmacologic interventions, or if the symptoms are sufficiently severe. Severe failure to thrive because of feeding problems or seizure activity. That's certainly a point to start a medication. The things that we use include some opiate replacements, morphine and methadone, much as you might use in detoxification in adults. These decrease incidence of seizures, improve the feeding, and eliminate a number of the symptoms, including diarrhea and agitation. Clonidine is used as an adjunct therapy along with opiates. It's thought that through its central activity that it stabilizes the autonomic nervous system. And so things like temperature instability, tachypnea, and those types of symptoms are improved. And then another adjunct that is oftentimes used is phenobarbital. When introducing both phenobarbital and a opiate replacement, the duration of exposure to an opiate can be decreased significantly. The downside to this is that it requires a significant wean from phenobarbital over the course of about 3 months. There's a lot of concern about the neurodevelopmental outcomes that follow prolonged exposure to a sedative like phenobarbital. So with the time that we have remaining, what I thought I would do is introduce some of the personalities that are a part of our working group and use those individuals and the questions that they have raised to highlight some of the gaps in the knowledge that we have around neonatal abstinence syndrome. A lot of the work that's being published right now is being done on a population level. Individuals are looking at discharge databases and insurance rolls to glean information about NAS. And so we have a very unique opportunity here with the rates of neonatal abstinence syndrome in our region to really impact our knowledge in this area. Dr. Wood is the chair of pediatrics, my boss, and has graciously joined us today, so I better get this one right. I've also chosen to highlight this one first for you because I think that this is an area that will appeal to psychiatrists. There is a study that was published back in the 90s called the Adverse Childhood Experiences Study, ACEs for short. And what this study demonstrated was that a number of unhealthy behaviors in adults and, quite frankly, conditions in adults relate back to adverse exposures in their childhood. And so Dr. Woods brought to the group an interest in administering the ACEs scale to expectant mothers or those that have recently delivered who are using a medication, either illicitly or through a medication-assisted treatment program, to understand what is driving the rates of opiate use in our in our region. The study came out of the West Coast through the Kaiser Permanente group. They abstracted the charts of adults who presented for a annual visit to glean what kind of risky behaviors, things like smoking, alcoholism, drug use, high number of sexual partners existed, and also what kind of chronic medical problems existed. They looked at ischemic heart disease, COPD, diabetes, cancers, among others. And then they issued a survey. They had a really, really strong response rate, somewhere in the 9,000 range, just shy of that, of adults who responded to this survey. This survey looked at 7 domains of what they termed adverse childhood exposures. 3 of those were abuse, physical, emotional, or sexual abuse. And then 4 of those were termed measures of household dysfunction. Was there mental illness in the household? Was there substance abuse in the household? Was there any evidence of criminal activity in the household? And was the mother abused in the relationship? And what they were able to demonstrate through this study was that a graded relationship exists between the number of domains that an individual has of exposures and the likelihood that they would participate in risky behaviors or ultimately have a negative health outcome. For example, in an individual that had no exposures, no adverse childhood exposures, 56% of those had no risky health behaviors. They looked at 10 behaviors. 56% without any adverse childhood exposures had no risky behaviors. And only 1% of those had 4 or more of those behaviors that we're studying. Contrast that to those who had 4 exposures on in the domains of the ACEs study. 14% had 0 risky behaviors, while the number who had 4 or more risky behaviors increased to 7%. This relationship existed at 1 exposure, 2, 3, and then 4 and more. They also demonstrated a similar relationship between disease outcomes. Ischemic heart disease, cancer, COPD, hepatitis, and skeletal fractures were all shown to have a graded relationship with the number of adverse childhood exposures. The model that came out of this is that there may be 2 contributions from adverse childhood exposures. One is that as children are developing, they adopt unhealthy behaviors, risky behaviors, to cope with the stressors in their life. The second hypothesis is that just a chronic state of stress results in some of these conditions. And so in a second wave of surveys, the authors of the original study looked more closely at drug abuse and found a similar graded relationship between the initiation of drug use in early adolescence, mid-adolescence, adulthood, and lifetime likelihood of drug use. By graded relationship, in this scenario, I've shared the odds ratios with you there. Let's take the case of a child who was in early adolescence. One exposure to one adverse childhood domain resulted in a 1.4 times risk, or a 40% increase in the likelihood that they would initiate drug use in early adolescence. If you had exposure in 2 domains, the odds ratio went up to 2.8. 3 domains, 4.2. Somebody with better math, correct me on that. So that's how that data is interpreted. They went one step further and tried to estimate how much of lifetime drug use can be attributed back to adverse childhood exposures. and estimated that between 1/2 and 2/3 of the risk of drug use can be explained by a adverse childhood exposure. And so what Dr. Wood is interested in doing is administering that same survey in our region and trying to figure out what is it that's unique about our region that increases the use of opiates. The second person I'd like to introduce is Beth Bailey, and I think she gave a grand rounds a couple of weeks ago, so somebody that you may be familiar with. She has experience looking at long-term consequences in other exposures. I believe that her research has been in smoking, alcohol, and cocaine. And so she's interested in applying that same experience, or her experience in studying long-term outcomes, to the long-term outcomes of opiates. There's actually fairly little known in this area, and what is known has been poorly powered to distinguish what are the effects of an opiate exposure versus what are the effects of actually going on to develop neonatal abstinence syndrome. So some observational studies have shown that we have decreased cognition and language development in the first 3 months, decreased gross and fine motor skills along with language and cognition at 6 months, decreased cognitive function and social function in the toddler years, and then in your preschool and kindergarten years, decreased executive function. A very recent article, and by that I mean it was published actually as I was preparing this talk, and I had to throw it in there, looked at outcomes in high school in Australia. The authors looked at the performance on standardized tests in 3rd, 5th, and 7th grades, and found that in each of these grades, there was a progressive decline in performance for those who had had neonatal abstinence syndrome. Progressive meaning if you were a year behind in 3rd grade, by 5th grade you were 2 years behind, and by 7th grade you were 3 years behind. And that's the extent of what we know. As I mentioned, these studies haven't been powered very well to distinguish what are the effects of opiate exposure versus actually developing neonatal abstinence syndrome. And so Dr. Bailey has proposed developing a longitudinal cohort study, looking at those who have been exposed but have not developed neonatal abstinence syndrome, those who were exposed and developed neonatal abstinence syndrome, and then a control group that's matched on factors such as gestational age and socioeconomic measures for the family. Dr. Welt recently retired from the OB department, and I cannot for the life of me remember who took over his high-risk practice, so he still gets credit for bringing this question to us. He, in the months leading up to his retirement, was weaning mothers off of, expectant mothers, off of opiates during their pregnancy. And he's interested in seeing if that would actually decrease the rates of neonatal abstinence syndrome that resulted. The foundation for that comes from a single study that came from some of our colleagues in Knoxville. Last year, a report was published that looked at 4 different cohorts of women. The first cohort was acutely detoxified while in prison. The second cohort participated in an inpatient detox program while pregnant, and then an intense outpatient follow-up program. The third cohort participated in the same inpatient detox program, but then didn't have outpatient follow-up. And the fourth cohort was slowly detoxified as outpatients. And what this study sought to demonstrate was the safety of detoxification during pregnancy. What they also found, though, was that the rates of treatment for neonatal abstinence syndrome closely mirrored the rates of relapse among their cohorts. So they went back and did an ad hoc analysis and found that in the cases of neonatal abstinence syndrome that required treatment, they either had documented evidence of relapse. Either mom said, yes, I relapsed, or we had a positive urine drug screen on mom, at some point during the pregnancy. Or the meconium, which is the method that they use to screen infants for exposure, was positive. We are just now starting to see the first patients from his clinic delivering, and so we are hoping that we can follow up some of these conclusions that were drawn out of this paper and demonstrate that indeed rates of neonatal abstinence syndrome are decreased if mothers wean during pregnancy. But it's hard to draw too many conclusions from the ad hoc analysis of that study. And then I saved my my project for last, figuring that if I talked really fast and needed to fill some time, I could talk about this all day long, or if I talked too long, I could shave it off a little bit. My interest, drawing off of my business background a little bit, really looks at resource utilization. Right now, we monitor infants for somewhere between 4 and 7 days, based on what we think we know about the half-lives of these medications in neonates. And when we look at studies that seek to capture infants that are going to require treatment, it's been confirmed that infants that require treatment are probably going to be identified by that 5th day. Smirk and colleagues did a retrospective review on 200 cases and found that 95% of infants are going to require treatment by that 5th day of life. And in the case that I think there were 2 cases in that 5% that were missed, those children were already suspected by day 4 or day 5. They just didn't require treatment until day 6 or 7. So all children who would require treatment could be captured within that 5-day interval. I'm interested in kind of taking a different approach, though, and asking, is there a way that we can identify infants that won't withdraw? Similar to what we did with neonatal fever about 20 years ago. Can we identify those that aren't going to have bad outcomes and hopefully discharge them a little bit faster? If I have to have an overlapping group, that gray zone, stay a few days longer, that's great. But if we can get 20, 30, 40% of these kids out of here faster than 5 days, that would be a great accomplishment. I think that leaves us about 5 or 10 minutes if there are any questions.